Hello, my name is Sepideh Amin-Hanjani from University Hospitals Cleveland Medical Center and Case Western Reserve University School of Medicine. I'm the immediate past chair of the Stroke Council, and it's my real pleasure to be having a chance to discuss with one of the principal investigators of the EMBOLISE trial, Dr. Jared Knopman, some of the results of this really significant study. So Jared, can you tell us a little bit about the design of the EMBOLISE trial and what question you were seeking to answer with this?
So the EMBOLISE trial, which was really two trials in one, was looking to see what the role was with embolization of the middle meningeal artery with Onyx in treating subdural hematomas. And when I say two trials in one, a couple of years ago, we were here presenting the surgical data, which was the role of MMA embolization as an adjunct to surgery. And this second arm, or what we'll refer to as EMBOLISE 2, is really the non-surgical patient population. And what's the role of observation in that patient cohort versus embolization and how their subdurals turn out?
Yeah, I mean, chronic subdurals are a really prevalent condition, as we know. Tell us a little bit about what the main results were from the study.
Yes, predicted to be the most common neurosurgical pathology by 2030, so these affect a lot of our patients. The main results of the study showed that middle meningeal artery embolization with Onyx was superior to observation alone, specifically a twofold reduction in the primary composite endpoint, which was made up of either need for surgical rescue, poor clinical outcomes, or clinical deterioration.
How did you adjudicate these outcomes?
These were CEC adjudicated. The clinical outcomes were based on MRS score, Mark Walder grading score, and the surgical outcomes, which were CEC adjudicated, were based upon both site and CEC adjudication.
Tell us a little bit about any complications that might have been encountered with the procedure. That's often the issue that comes up in decision making, is whether to proceed with a procedure, knowing that there is some risk of peri-procedural complications versus the longer term primary outcome, which you did see a benefit in.
Yes, especially in a patient cohort which is mildly symptomatic, like this observation cohort, safety is of the utmost importance. We didn't find a statistically significant difference in death rates. We did see, concerningly, a higher stroke rate in groups that underwent treatment versus those that didn't. When we did a deep dive into those strokes, 5 out of the 6 that we saw were very preventable. And what I mean by that is those were due to a combination of either procedural factors or stopping of antiplatelet, anticoagulant medications. So we also found some risk mitigating factors that we learned as well.
And what do you suggest then in this scenario to help reduce that risk of complications?
The procedural risks of stroke were related to internal carotid artery catheterization, which oftentimes is not needed for this procedure, doesn't add efficacy, but adds an extra step. And the medical side of the story is equally important. Not stopping medications, anticoagulants, antiplatelets, especially in a patient population which has comorbidities and secondary stroke risk factors. By adhering to those, we can mitigate the risks of blunting the robust clinical responses that we found.
Okay. And given the frailty of this population, often elderly patients with comorbidities, are there patients based on your trial's selection criteria that you think would perhaps not be good candidates to undergo MMA embolization?
Yes, we looked at more mildly symptomatic patients here with smaller subdural hematomas, but the key is that they had symptoms. So I think taking a very small chronic subdural hematoma with no symptoms, that I think would be a little bit aggressive to necessarily going in and embolizing up front. And then when you are proceeding with the procedure, if you're in there and recognize that the arch is difficult or access is challenging, having a lower threshold to stopping the procedure in this more mildly asymptomatic patient population is also prudent.
Okay. And finally, can you give us a sense of where you think these results lie in the context of other trials that have been published in the last couple of years in this space?
We've seen some trends in some of the other trials as well, showing the same findings. EMBOLISE 2 is the first and only trial powered to look at this more mildly symptomatic patient population. So the trends that we've seen previously, we think we've confirmed in a more robust fashion.
All right. Well, thank you very much. Certainly, I think practice-changing results that come from this trial. Congratulations to you and your co-investigators on this study.
Thank you.